right age. And we said that in addition to that, there are a great many, we only talked about a few, but a great many mechanisms that regulate flow peripherally. We define flow as the amount of blood passing a point at a certain time. So velocity is distance over time, flow is amount over time, and then now we're going to talk about pressure. Pressure is a little bit more difficult to define. We're just going to continue with the definition we've used to this point. Pressure is the force exerted by the blood on the wall of the vessel. And of course, to recapitulate, the primary pressure determinant is the heart. What we haven't explored and what you need to appreciate as we continue our discussion is the vascular relationship between velocity, flow, and pressure. So we're going to explore both of those general concepts as we go, the central pressure regulation and the peripheral pressure regulation. Now, for the test this morning, you had to know pulse pressure. You know, pulse pressure is just the difference between systolic and diastolic. But we looked at a diagram like this before, and we found that there were grave differences in the extent of the pulse pressure, the size of the pulse pressure, depending upon whether we're in the heart or whether in the proximal arteries or the distal vessels. And we also found, and that's what is shown by this dashed red line here, that mean arterial pressure also tends to decline as we move from the left ventricle all the way to the capillaries. In fact, this is a little bit inaccurate because the absolute amount is not quite correct. That's all right. It illustrates the general point. What you need to be able to do for the final test is to calculate mean arterial pressure on the basis of this very simple formula that is often used clinically to provide an estimate. And basically the little equation, a little arithmetic that is used to estimate mean arterial pressure is the following. It's the pulse pressure divided by 3, or just 1/3 of the pulse pressure, plus the diastolic pressure. Why do we add there are a number of levels, a number of reasons why this may not seem intuitive. Why don't we add the systolic pressure instead of the diastolic pressure? Or subtract it from the systolic pressure? In other words, we could come up with a formula. If I were to ask you to come up with a simple formula to estimate mean arterial pressure, the simplest thing we could do is just take systolic and diastolic and divide it by 2, right? The sum and divide it by 2. Why not? That would be a mean. Why not? All right, so this equation, the answer was that our heart is a diastole longer than in systole. So this equation is all designed, and it's just an approximate, just an estimate, to favor the interval of time and the relative contribution to diastole over systole. So not only are we not dividing the pulse pressure by 2, we're dividing the pulse pressure by 3, and then we're adding that to diastolic pressure. So be able to, for whatever numbers I give, we can do it now, for example. Let's say the systolic is 160 and the diastolic is 100. What would the mean arterial pressure be? Systolic is 160. We've got a sick patient here. Systolic is 160. The diastolic is 100. What's mean arterial pressure? All right. So somebody break it down for us. What are we going to do first?
120.
All right. So both of you gave us the right number, but I want to break it down. Tell me how you calculated it.
I've always just doubled the diastolic pressure, added the systolic, and then divided by 3.
That would give you the same result.
That's what I learned
I don't know why you do that, because to me this is simpler. But
We just gotta remember 1, 2, 3.
So say it your way again, and maybe you can use whichever formula you want. But just
Double the diastolic,
Right.
diastole,
Right.
add the systolic, and then divide by 3.
Yeah, you're doing the same thing.
Just I remember it for 1, 2, 3. Put it together for the formula.
But for testing purposes, just make sure we're all on the same page. The Pulse pressure divided by 3, because that's the difference, right? So when you add pulse pressure divided by 3 plus the diastolic will also yield the arterial pressure. Actually, when you do what you say you're doing, sometimes you might get a slightly higher number at low pressures, I think. But I'll have to work through that.
Yeah.
I'm too tired to go through it right now. But for any two numbers, we can do some more if you want, but for any two numbers, be sure you can form that little simple arithmetic. So that's mean arterial pressure, and you can see that it's declining as we, again, move from the aorta to the capillaries. And so pressure, by the time we get back to the right atrium, is going to be very, very small. A few other general determinants, important determinants of overall arterial pressure. Certainly, blood pressure, arterial pressure, is going to be related to overall blood volume. So the greater the total body water or volume of blood of your patient, the greater the blood pressure. So if a patient is hypervolemic, they're likely to be hypertensive. If they are bleeding out, and the body hasn't gone into sufficient compensation, they're likely to be hypotensive. So again, relate volemia to pressure. Now that's central. There are a number of compensations that the body can implement in response to a deficiency of total body water or blood volume, hypovolemia. Peripheral vasoconstriction. Again, vasoconstriction is going to increase blood pressure peripherally. Sympathetic stimulation of the heart, increasing cardiac output. That's going to be a momentary or transitory compensation for insufficient volume. And then, of course, what do we mean by replenishment? What do you, if you have insufficient blood or total body water, what will your brain tell you to do? Yeah, you're going to be thirsty. You're going to want to drink. A lot of this is mediated, as we've indicated before, by the cardiac centers in the brainstem. We've also pointed out that we've talked about the venous pool, the fact that at any given time, most of your blood resides in the veins because the veins are more compliant. But the veins are capable of some degree of vasoconstriction, and if the blood, and just sort of think this out, if the blood is shifted for whatever reason from the venous compartment to the arterial compartment, what's going to happen to blood pressure? Go up or down? Arterial blood pressure is going to go up. So make sure if there's any diversion of blood from the venous pool to the arteries. So that's all we're talking about here. Seems like there was one other thing I wanted to mention here. All right. So how does the body regulate blood pressure? What is the mechanism by which this occurs? You have at several points, two primary points that are indicated here anatomically are in the aorta and in the carotid sinus. You have several focal concentrations of baroreceptors. The baroreceptors are sensitive to blood pressure. Basically, they're just stretch receptors, and they're monitoring the distension of the vascular wall. So as the aorta stretches, as the carotid sinus stretches, that will increase the frequency of action potentials sent either along the vagus nerve from the aorta or the cranial nerve 9, the glossopharyngeal, from the carotid sinuses. And of course, those signals are going back to the brainstem. And so how would the body respond to increased distension? What would the brain tell the heart to do? Lower cardiac output, lower heart rate, lower contractility. And that hopefully over a relatively short period of time, generally within just a couple of heartbeats, restore the blood pressure back to normal. So be aware of the two locations of these baroreceptors and how their reflex response is important for compensating for elevated or, for that matter, insufficient blood pressure. And we've talked about orthostatic hypotension. You should be able to tell me what that means. We talked about venous return, the relationship to central venous pressure. What I want to focus on now is the autonomic compensation, the autonomic response to orthostatic hypotension. The baroreceptors that we just talked about, located in the carotid sinus and the aorta, are going to detect that decreased pressure. And so the autonomic response that we just mentioned, increased sympathetic activation, PNS activation is decreased, heart rate goes up, the force of contraction increases, both causing an increase in cardiac output and presumably a restoration of normal mean arterial pressure. And you have several illustrations here. For some reason, I put about 2 or 3 illustrations showing the same thing. But for example, let's look at this one. If the blood pressure is decreased, all right, we have insufficient or low blood pressure, that means the stretch receptors are going to send a lower frequency of action potentials back to the brainstem. And how will the brainstem compensate? Decreased parasympathetic activity, elevated sympathetic activity, and as we've indicated before, elevated cardiac output.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata. As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
And of course, as usual, I made my little flash animation too long. Okay, so let's talk a little bit about the relationship between these 3 terms down here. Folks sometimes have trouble with this. Just make sure that we're all on the same page and understand the relationship. So we know that, well, you tell me, if I increase pressure, all else being equal, what should happen to flow? Should it go up or down? All right, so pressure and flow are directly related, provided there are no other considerations, which unfortunately is never the case in the human cardiovascular system. What is the relationship between velocity and flow? So as I increase velocity of blood in a blood vessel, what should happen to flow? Should it go up or down?
Up.
Increase or decrease? Increase velocity, what should happen to flow?
Increase.
Increase, all else being equal. All right, so make sure you understand we have a direct relationship between all of these if we don't have any complicating factors such as vessel size. All right, so what do we know happens when the diameter of the vessel is decreased? Does pressure go, well, let's start with the simple one first. Does velocity increase or decrease as I reduce the diameter of the vessel? Does velocity go up or down?
Down. No, up.
Right? Increase. Velocity increases. So make sure you understand that. Velocity increases as I decrease the diameter of the vessel.
Mm-hmm.
This is like, think of taking a raft down a river, and you're down the river is really, really wide, but as it narrows through the Grand Canyon, or the Grand Canyon, what happens to the velocity of your raft? Does it increase?
Yeah.
So, and we have the same principle for the garden hose, right? I don't want to wake the people up in the back of the room. They're all gone now anyway. But if I did, I would need to restrict the vessel size. All right. The diameter of the garden hose. The complicated one is pressure. And this is a little bit more difficult. Now, we can talk about a model, but also what happens in reality. So remember, in general, in the human cardiovascular system, when vessels change size, they do so over relatively long lengths simultaneously, or at least that is a good approximation. Whereas if I'm talking about regulating or changing, let's say we have a garden hose here, and let's make it a fire hose. Let's make it exciting. So it's a fire hose, and the water is coming through, and I'm putting my foot on the fire hose. Now, as I put my foot on the fire hose, you tell me, this is proximal, that's distal. Water is flowing this way, could be water, could be blood. As I put my foot on the fire hose, what's going to happen to the velocity of blood flow, velocity of water flow, increase or decrease distally?
Increase.
Increase. All right. What's going to happen to flow? Is it going to increase or decrease distally?
Decrease.
Decrease. Everybody got that? All right. Now, what about pressure? Putting my foot on the hose, what's going to happen to pressure distally? Is it going to increase or decrease?
Decrease.
Right?
Decrease.
Decrease. All right. This is a little bit tricky. What's going to happen to pressure proximally and at the constriction? Go up or
Increase.
down? Increase. All right. So we have to make a distinction here between proximal and distal. Pressure increases proximally, decreases distally. Remember the relationship between flow and pressure. If I decrease the pressure, I decrease the flow. If I decrease the flow, I decrease the pressure. Only complication here is vessel size. Any questions about that? I never know, sometimes folks have a hard time with that. Sometimes it's relatively straightforward. So again, don't confuse velocity and pressure. The speed at which the fluid is moving is not necessarily related to the pressure, especially as we change the size of the vessel. All right, we're looking at a graph. We have a figure here. We have arterial pressure over time. Arterial pressure over time. So we have a normal sort of aortic pressure wave here with systole and diastole. So the middle one here is arteriosclerosis. We're looking at the vascular pressure, arterial pressure, and arteriosclerosis. Somebody explain to me what that means. First of all, what is arteriosclerosis?
Plaque formation.
Effectively narrowing. It's hardening. We're going to be careful here. Strictly all it means, it's not the same as atherosclerosis. I guess it is in all the literature now. But technically, arteriosclerosis just means that the walls of the vessel are hardening. They're becoming less compliant, becoming less elastic. And as that happens, or we talked about copper pipes before, I think Evan brought that up. So as that happens, as those vessels become less compliant, the pressure increases in those vessels. It's effectively the same as narrowing because they no longer have the ability to absorb the pulse pressure gradient. What about over here in aortic stenosis? What is aortic stenosis? Narrowing of the aorta. And so what is the effect there relative to normal and why? Why? Somebody explain that to me.
Decrease in pressure because you're losing flow.
I think so. I think that's the best way to express it. Everybody understand that less blood is escaping and can pass through the aortic valve. It's again like me putting my foot on the fire hose. If I cut off the fire hose completely, there's no pressure, there's no flow. So the stenosis is decreasing the flow and therefore decreasing the pressure. Now, what about the pressure in the ventricle? Increasing, leading to perhaps what? What pathological condition of the heart? Hypertrophy. But again, suggestive that the pressure proximally is increasing. So you already know all about autonomic regulation. I'm not sure I'm too happy with that. Why did I draw a line through parasympathetic activation dilates vessels? Yeah, only in a few tissues. Even in the lungs, it's not very important. Mostly glands, some other tissues. So remember, most vasomotor regulation is sympathetic. And sympathetic activation can either dilate or constrict vessels in a tissue-dependent fashion. What will determine whether the blood vessel, smooth muscle, relaxes or contracts in response to sympathetic activation? The receptors, right. Could be alpha, beta 2, could be alpha receptors, beta 2. That would be the determinant. And then know your pathways. This is just a reminder that you should recall the pathways for all of these autonomic circuits. And then remember when we talked about smooth muscle activation, will you remember that peculiar terminology? Those sympathetic or autonomic threads with the varicosities releasing neurotransmitter onto the smooth muscle, depending upon whether it's single unit or multi-unit. And remember, what is the activation pathway? You should be able to tell me at this point what happens when that adrenergic receptor is bound. What's going to happen inside the cell? What's the pathway that activates the smooth muscle relaxation or constriction? Well, even more, it's just a G protein pathway. In most cases, it is going to be a cyclic AMP, but you know that because this is an adrenergic neurotransmitter. So don't lose sight of all of those things you learned earlier in the semester. All right, so with respect to sympathetic or generalized sympathetic activation, we're going to get systemic vasoconstriction as a rule, but again, it's going to depend upon the tissue. Let's talk about that a little bit. We've talked about it before. Make sure you understand what I mean by this. So when we talk about systemic vasoconstriction, let's say sympathetic activation affecting blood vessels in the smooth muscle of the GI tract. Sympathetic activation will affect blood vessels of smooth muscle in the GI tract. What's going to happen there?
Muscle constriction.
Right, it's going to be vasoconstriction. What about skeletal muscle? Sympathetic activation. That dilation. So once again, just be sure that you understand this is going to be tissue specific. If there is systemic vasoconstriction, then total peripheral resistance will increase. Respiratory cardiac output is increased. And those are the primary mechanisms. But it says here capillary pressure is reduced by arteriolar constriction. Capillary pressure is reduced by arteriolar constriction. Someone explain that. Why would capillary pressure be reduced by arteriolar constriction? I thought the speed, the velocity would go up. Exactly right. My foot is on the fire hose as I am. Which comes first, the arterioles or the capillaries?
Arterial.
Arterioles. I'm restricting the arterioles. The flow drops. Capillary pressure drops because distal, remember, pressure and flow are directly related. Everybody got that? I reposted these slides this morning. Hopefully everybody has this little table. All right. I just wanted you to see this again. The point I was making earlier that vasomotor tone is primarily determined by sympathetic factors. We've already talked about all of these. So the little positive signs and negative signs on the heart, sympathetic increases chronotropy, parasympathetic decreases it rather powerfully too. And sympathetic effects are sympathetic inotropic effects are more important than parasympathetic and so on. So that's all those little positive signs mean. But this is the one that I wanted you to pay attention to here. So what would a beta blocker do? What beta block? What are we blocking? And why would this present a bit of a complexity, a bit of a problem in trying to predict the response? All right, so Bob is asking about the nature of the receptor. We know beta 1 and beta 2, for example. Beta 2 normally does what? That's relaxation, smooth muscle relaxation. What does beta 1 do primarily?
Constriction.
Right? Yeah, it's going to, in fact, it's going to increase the activity of the heart. So if here's the, let's say I have a beta agonist. What's going to happen if I give the patient a beta agonist? What should happen? You can begin to see why this is a potentially difficult thing. So if the patient is given a drug that binds these beta 1 and beta 2 receptors, what's going to happen to the heart? What happens to the peripheral blood flow? Or what happens to pressure peripherally? We bind those beta 2 receptors. Beta 2, those are what? Do they constrict the vessel or relax the vessel? Relax. Right, so cardiac output is going up, and flow pressure should be going up or down peripherally? Down. All right, does that make sense to you?
No.
All right, let's work it the other way. Somebody explain a beta blocker to me, both in terms of the heart and the peripheral circulation. Beta blocker. CO, going to go up or down? Cardiac output goes up or down? Down.
No.
And what happens to peripheral blood flow? Does it increase or decrease? Well, again, if I'm blocking them, the blood flow is going to decrease. What I'm asking you, in either case, does that make sense? Why or why not? What would happen if we decrease cardiac output and increase peripheral flow? Does that sound like a recipe for success?
No.
Why or why not? Well, possibly. But if the ability of the heart, you're right, the ability of the heart to pump the blood is diminished, and I'm lowering systemic blood pressure, increasing the path for the blood to flow, that's pretty much going to lead to what? Think about our discussion of hyper and hypotension. Well, not necessarily. Yeah, the patient's probably going to be hypotensive, right? I wanted, basically what I'm asking you to do, and I'll let you think, because I think all of us are probably exhausted right now, is why don't you, before the final exam, hint, be able to tell me the possible effects of a beta blocker in particular with respect to beta 1 receptors and beta 2. So anticipate the consequences of binding at both sites. I think this was a question on your test with respect to the ability of extrinsic factors such as hormones to regulate blood pressure. And in general, they do that by one of two mechanisms, either by changing blood volume or by changing vasomotor tone. In some cases, both. So, for example, epinephrine, I think this is one you already should know pretty thoroughly, is going to elevate cardiac output via both dromotropic, inotropic, and chronotropic effects. And it can have, again, tissue-dependent effects on blood vessels, either relaxing the blood vessels, relaxing the smooth muscle, or constricting the smooth muscle. There are two hormones we really haven't talked very much about. We talked about ADH with respect to being a posterior pituitary hormone. We said that ADH stands for antidiuretic hormone. It is also arginine vasopressin, which tells you something about its effects. With respect to the concept of a hormone being antidiuretic, how would that affect blood pressure? It's going to increase blood pressure. Why or why not? What is diuresis? It's wee-wee, right? It's urination. And so if you are stopping the ability, if you're reducing the ability of the patient to urinate, the patient will retain more water. That's hypervolemia, and that will will increase blood pressure. So be sure you understand the wording of this. ADH reduces water loss from renal tubules in response to elevated blood osmolality or decreased blood pressure. This also has an effect, the pathway also has an effect on blood pressure. We'll talk about that, especially as it relates to this hormone 2, the aldosterone, released in response to renin and angiotensin, is also an antidiuretic. So it would also have an effect on blood volume. We're going to find that angiotensin also has an effect on vasomotor tone. We'll work through all that later when we talk about the kidney. But what I want you to appreciate now is these two hormones, one released from the adrenal cortex in response to a renal hormone, and this one released from the posterior pituitary, both have effects on total body water or blood volume. This is a little illustration. We won't take too much time because you're going to be spending a lot of time talking about this. We can't spend too much time talking about this here because we didn't talk about turbulent and laminar blood flow. Turbulent and laminar blood flow. But when you take your stethoscope, and in the old days when you take the stethoscope and you would measure the patient's blood pressure via the brachial cuff and the little stethoscope placed distally there, distal to the elbow. What are you actually listening for? What's causing the sound? Not exactly, and you have a picture of that over here. You can see this is the degree to which the brachial artery is open. What you're listening for is the sound of the blood rushing through the brachial artery. And if you just put your stethoscope on at this location without the cuff, you're not going to hear a whole lot. You're not going to hear a lot of noise or sound at that point. So when you put the cuff on, you inflate it, you know how pleasant that is. It cuts off all blood flow to the arm. Are you going to hear anything? You're going to hear any blood flow coming through? You're not going to hear anything then. All right, so as you know, then the pressure in that cuff is slowly reduced until the cuff pressure drops below what? Systolic pressure. And you can see what's happening over here. Now that brachial artery begins to open just a bit, but the blood is moving through that narrowed artery in a turbulent fashion. And it's really the turbulence of the blood flow that you're listening. And the cuff pressure continues to decrease. Drops, until eventually the cuff pressure drops below diastolic pressure, at which point you're here again. There's really no restriction, and you don't hear the quality of the sound again changes rather dramatically. So my point here, and you can read through this if you wish. Excuse me as I recover. I'm just trying to regain my composure. I've been insulted in a variety of ways over the years, but I've never been usurped by Siri in my final death throes of getting on after 4 hours of lecture. The hubris, the humanity of it all. By the way, I much prefer. Does anybody have an Amazon Echo? Oh, it's wonderful. The Echo is my best friend. It puts me to sleep at night. It wakes me up in the morning. I can tell it to play anything, and it plays it for me. It gives me it's just wonderful. All right, so I want to make sure you understand. We didn't talk very much about laminar and turbulent flow, but I do want you to appreciate that what you hear in brachial manometry, sphygmomanometry, is just turbulent flow in the brachial artery between systole and diastole. And you will learn the techniques and the qualities of sound that can be perceived. But I think this is a nice illustration of that concept. Of course, this is a little slide illustrating hypertension, and clinically you want to be aware that hypertension is destructive on a number of levels. It increases the risk of capillary events and strokes in the brain. It can be destructive to the retina of the eye. Certainly the renal capillaries can be destroyed, leading to some various types of nephropathy. And of course, the heart can become overworked and eventually hypertrophic as well. So this is an insidious and destructive process. In many cases, the consequences of which are not fully understood until it's too late. They keep changing these values, but I think I think the stage 1 hypertension is still accurate. I think the trend or the tendency is to move it down lower, right? So I think they want to move toward 130 or even 120. I think now is considered an important threshold. So 120 to 140 would be pre-hypertension, and the idea in general is to keep blood pressure as close to normal, as close to 120 over 80 as possible. And then your clinical coursework, you'll discuss the relative importance of elevated systole versus elevated diastole. I think the prevailing opinion now is that you need to pay attention to both. It's not just one or the other that should receive priority. Is there a relationship between salt intake and blood pressure? Anybody keeping up with this debate? It's about 6 of one, half a dozen of the other. For every article you can find showing a relationship between salt intake and blood pressure, you can find one that shows there is no relationship. So it's a little bit confusing at this point. But the consensus currently is that probably, unless the patient is already hypertensive, it probably is not as important as other factors. All right, any questions about the blood pressure? If not, let's call it a day.